So this is my third presentation of the day today, and switching tone from ophthalmology. This is the case from internal medicine, from the hospital medicine department, actually. So the title of the presentation is E-cigarette or vaping is use associated lung injury, aka E-villi, in a nicotine-dependent male with COVID-19. I'm Leo Meller. I'm again the presenting author, and my co-authors are Dr. Kwan and Dr. Gupta for San Diego's hospital medicine department. So background. E-cigarette or vaping use associated lung injury, I'm going to abbreviate it as E-villi from now on. It's an acute, novel, severe respiratory condition characterized by lung inflammation due to inhaled substances. However, given its overlap with other pulmonary condition, the diagnosis can be easily overlooked. I just want to preface by saying that E-villi was recently in 2020 became a diagnosed disorder, and currently there's very little information that's known in regards to how it typically presents and how to properly diagnose it. So the case presentation is the patient was a 22-year-old male with history of tobacco use disorder, presenting with 1 day shortness of breath, non-productive cough, and fever after inhaling vaping oil. He was unvaccinated for COVID-19 and tested positive. However, he did not seek contacts, but he was living at the sober living center, so we suspect that that's perhaps where he caught it, where there was other individuals living with him as well. His initial vitals of presentation was he had a fever, blood pressure was 149/90, heart rate was 145, respiratory rate was high, 50 to 60 per minute. Oxygen saturation was 86%, 87%. So he was on 9 liters of nasal cannula. On exam, he was anxious. However, his lungs were clear to auscultation bilaterally. So for workup, initially we ran a chest CT angiogram. However, that was negative for pulmonary embolism, but it shows significant numerous airway center nodules, more prevalent on the right lung, and moderate pulmonary edema as well. And chest X-ray reviewed ill-defined basilar opacities accompanied by right pleural effusion. For a lab test, he was SARS-CoV-2 positive, like I just mentioned. He had elevated white blood cell counts with left shift and no more procalcitonin. And they made this interactive diagram for disease course to help illustrate his presentation timeline. So first, he came to the UCSD ED with 1 day shortness of breath and non-productive cough. And from there, he was admitted to the hospital given the severity. On the CTA chest, even though we couldn't pull up the CTA chest image because of our EPIC reasons, however, we showed the CTA abdomen here on the right. I also showed the same basic things on the lungs, which is numerous airway nodules that was more abundant on the right lung compared to the left. And then given his presentation, we started him on cifotraxone, and as this I think empirically, just in case that he might acquire any community-acquired pneumonia, given his presentation, it was similar to that. And we started him on COVID-19 medications, as well as prednisone, 60 milligrams per day for E-villi, to decrease the inflammation caused by the vaping oil. And then on day 2, we ran chest X-ray that showed increased right pleural effusion as well as increased basilar opacity associated with worsening sequelae of E-villi. And ultimately, we diagnosed him with E-villi versus other things because of the constellation of acute symptoms, close temporal relationship of vaping use and presentation, no suspicion for infection based on imaging lab values. And he was on a 3-day course for COVID-19. On day 4, patient rapidly improved over the course of hospitalization with resolved hypoxia, because if you remember, initially he was on 87% oxygen saturation, and he was discharged on steroid taper. So discussion of this case, as a novel condition, diagnosis of E-villi is challenging. As I mentioned earlier, it is a relatively novel condition that started mainly in 2020, so it does lack formal diagnostic guidelines and criteria, and typically relies on exclusion of other conditions, such as in this case. In current literature, it shows that approximately 2/3 of the patients with E-villi are males, and 3/4 are under 35 years old, which is similar to our patient because our patient's also a male and is only 22 years old. So workup for E-villi typically should include assessment for different respiratory diagnoses, especially the infectious ones, such as community-acquired pneumonia. And you have to take a thorough history of e-cigarette or vaping use, because after all, this disease is associated with substance use, and evaluation of lung characteristics on chest imaging. Here, I'm a little smart figure. I'm not sure if you guys can see it very clearly or not, but basically, in this prison case, our differential diagnosis was E-villi versus pneumonia versus pulmonary embolism. And then we ruled out pneumonia because he had no more procalcitonin, showing that there's no active infection. And there was pulmonary embolism, but we ruled that out with a CTA that showed no PE. And the reason why we chose we believe that patient had EVALI was that his imaging was consistent with inhalation lung injury with the numerous airway-centered nodules on his lungs. And then also he had very extremely close temporal relationship between symptom onset and substance use. As I mentioned earlier in the history of the case, patients, everything started after inhalation of vaping oil. So we believe that that's the most direct cause, showing that this case is EVALI. And then in terms of treatments, typically you empirically start patients on antibiotics and antivirals just because you never know whether potentially it could be a comorbid community-acquired pneumonia case or simply purely EVALI. Like in this case, we started on cifotraxone and azithromycin just in case the patient had CAP. And patients with hypoxia or progressive worsening symptoms, you should also give the patients supportive care as well. Like in this case, we'll put the patients on non-lethal nasal cannula because he had a low oxygen saturation. So given the unpredictable prognosis of EVALI, physicians and clinicians have to be vigilant in assessing any substance use in patients presenting with conditions that's consistent with EVALI for timely diagnosis, treatment, and improving outcomes. And so the overall learning objectives of the case include that you have to understand the differential diagnosis of EVALI based on recent substance use, acute symptom onset, because EVALI is an acute condition, as well as signs of inhalation lung injury or imaging in the absence of other lung diagnosis. And we stress the importance of a thorough history in cases such as this. And that's the end of my presentation. Thank you.